Good afternoon, everybody, and welcome to our TIF Talk Tuesday. Today, I'm super excited to introduce everybody to Dr. Mamoon Raza. Dr. Mamoon Raza is an interventional gastroenterologist practicing in Elkhart, Indiana. He's performed about over 300 procedures since 2010. So, first of all, welcome, Dr. Raza, and thank you for being here today.
No, thank you. It's great to be here. I love doing these with you guys, and I look forward to getting the word out there about how we can better treat reflux disease.
Awesome. So today, Dr. Raza and I are going to kind of talk a little bit more about what GERD is and the TIF procedure. I highly recommend, if you're on and you're watching the Facebook Live event, to please go ahead and ask any questions you have today. This is your opportunity to ask a doctor a question, anything about GERD or TIF. So please feel free in the chat box to ask your question there, and we'll do our best to answer it today. So let's go ahead and start. Dr. Raza, first of all, I love your background that you have.
Yeah, it's
Let's talk a little bit about that. What is GERD? And maybe you can kind of show us the anatomical stomach, if you will, and esophagus, and explain a little bit of how GERD happens and what happens with symptoms of GERD.
absolutely. So, reflux, as it relates to the stomach and the esophagus and heartburn symptoms, means that contents from your stomach are rising up and ending up in your esophagus in an abnormal amount and an abnormal frequency. This can happen for a couple major reasons. The first is the sphincter, which controls the bottom of the esophagus and prevents things from coming up, doesn't function properly any longer. We don't exactly understand why that happens in some people, but we do know that that muscle stays open longer than it should and opens more frequently than it should. There's a normal amount of venting that can occur as part of normal physiology, but when that happens at a greater degree, that causes reflux. The second is an anatomical disruption, where you can see the horizontal line running next to the esophagus. That represents the diaphragm. And as you can notice, the junction between the esophagus and the stomach is supposed to happen below the diaphragm in the abdomen, as opposed to above the diaphragm, which would be the chest cavity.
Right.
What can happen is the diaphragm can separate and open over time for a variety of reasons. And we don't fully understand all of them, but we do know that they definitely runs in families.
Mm.
And that opening will allow the stomach to herniate up through. That
Mm.
opening in the diaphragm that allows the esophagus down is called the hiatus. And when that hiatus gets bigger and the stomach herniates through, that's how you get the name hiatal hernia.
Right.
And that will prevent a person from being able to control their reflux, independent of whether or not their sphincter muscle is working properly. Just the fact that the anatomy is now disrupted, um, reflux will occur. Now, the difference between run-of-the-mill heartburn that people may experience and
Mhm.
actual gastroesophageal reflux disease, or GERD, relates to symptom frequency and symptom severity. So if a person would experience heartburn symptoms, mild to moderate, more than twice a week, or severe symptoms more than once a week or more, we would consider that a disease or gastroesophageal reflux disease, as opposed to just run-of-the-mill heartburn that I'm sure all of us experience from time to time, depending on what we eat.
Yeah, I'm so glad you explained that, because a lot of times people think, oh, I have heartburn. Do I need the procedure? And so I like that you explained, at what point does it become a disease? I mean, then sometimes people that have had a type of a surgery or whatnot, they say that they have heartburn, once or twice a month, and that's great, right? Because
Right.
that's your body will normally do that at some point, if you eat a big meal or something that doesn't work with you or for you or your body. So tell me, can you explain a little bit about what are the treatment options for GERD, not just heartburn? Maybe more the for GERD, if you will.
Sure. It starts with things that you would normally want to do for any kind of uh, illness or kind of lifestyle problem, and that is lifestyle changes. So avoid eating too late at night. Try and limit some of the dietary things that can cause reflux. So there's a whole host of them, and I don't insist that people avoid all of their food triggers in order to manage their reflux. In fact, my expectation is to allow them to tolerate a normal diet. It's just when those things become egregious. So some people will admit to drinking, for example, an entire pot of coffee a day or several pops, including up to a 2 liter of pop a day. Well, there's nothing that we can really do to overcome that kind of behavior, and that's a behavior modification that has to occur. So
Sure.
independent of that, I joke with my patients. Well, it's not really a joke. I mean it seriously. If my doctor told me that the only way I could get over my illness is if to give up coffee completely and not even have 1 or 2 cups a day, I would find another doctor. So my goal is to allow for normal kind of dietary lifestyle,
Right.
and because that is a quality of life indicators is how normally can you live. Now,
Right.
normal again has to be defined, and there has to be some common sense applied to that. The next step would be using medications, and the idea behind medications is simply to change the acidity of the contents in the stomach. Medication that we have now does not prevent material from exiting the stomach and entering into the esophagus. It simply changes the acidity of it, thereby hopefully reducing the burning sensation or the actual heartburn. Because of that, people will often say that, yes, on medication, their heartburn is better, but they still feel things up in their throat, or they cough a little bit, or some other symptoms I'm sure we'll discuss in a little bit. And they don't have a complete relief of their symptoms with medical therapy. And that's actually very, very important because we want to identify those people and then offer them the next step. The next step is actually correcting the anatomy that we spoke of earlier, whether it be augmenting that sphincter muscle and allow it to work better or help it,
Mhm.
with or without repairing the hiatal hernia if it's present. So if it's present, obviously that needs to be corrected at that time as well. And without correcting the anatomy in people that do have these regurgitant symptoms, you can't really expect complete relief with just medication.
Right. Right. Fantastic. I appreciate it. Thank you. So what different you said lifestyle modifications, how can they imagine, and you talked a little bit about when should someone see a doctor, when, at what point, and then what types of diagnostic testings do they need to do in order to determine if they're a candidate for the TIF procedure or any procedural type.
Sure. So it would start by understanding again what we talked about is what is the definition of reflux disease. If you have a disease, you should see your doctor for it. So if it is frequent enough where you're having a severe symptom once or more per week, or mild to moderate symptoms 2 times or more per week, you should see your doctor. You
Right.
certainly can start with your primary care physician or primary care provider, and if symptoms are relatively mild, then certainly a trial of lifestyle modifications along with medication may be appropriate. If those measures do not result in complete relief of your symptoms, meaning you still have some regurgitation, cough, trouble swallowing, or other atypical symptoms, then you should not settle for that as
That.
the best that can be done. There
Yeah.
are other options, and you should be referred to a gastroenterologist for workup. That workup would include starting with an upper endoscopy and seeing what the anatomy actually looks like.
Okay.
We may at that time choose to pursue actual acid monitoring to see how much acid is actually splashing up into the esophagus so we can confirm the diagnosis. There are other mimics of reflux disease, usually motility problems involving the esophagus where it doesn't function properly. It may not be an issue of too much stomach content rising up into the esophagus. It may actually be an issue where the esophagus just isn't clearing properly, and
Right.
that's giving you the same regurgitation because when you lay back, things come up that were in your esophagus and never left. So sometimes we do need to differentiate and confirm that we're actually dealing with acid reflux. And
Okay.
if we're not, that might be why medication didn't work because the diagnosis was wrong.
Yeah.
Once that has been established what the anatomy is and whether a person truly has reflux, and if medication is not solving the problem, then we can start exploring the different surgical options.
Okay, fantastic. Thank you. We have quite a few questions that have come in through Facebook, so I'm going to go through them real quick. First one, we've got Dorothy Jansen. She's asking, how do you get rid of nausea from GERD?
Hi, Dorothy. The best way to get rid of nausea from GERD is to treat the GERD. So that is one of the atypical symptoms that can happen. This would be an important area where we'd want to exclude other possibilities of your nausea, whether it be a motility problem of the stomach itself, maybe not the esophagus, but maybe the stomach, maybe other issues like the gallbladder, and make sure there isn't any other pathology going on, such as a blockage in the stomach or an ulcer, et cetera, et cetera. If it is then established then that the nausea is indeed from reflux and the medication is not improving it, then we need to stop the reflux. And that may involve a surgical intervention.
Perfect. Wonderful. Thank you. We have another question. We had two questions about nausea, so I'm glad you explained that. So thank you. We've got another question from Jagrudi. Does it help non-acid reflux? Does the TIF procedure help non-acid reflux?
So that's a great question. Non-acid reflux may be defined two ways. One is its actual non-acidic material refluxing up into the esophagus, and that would be bile type material. And that's more alkaline, and therefore the pH studies would be negative. It can be determined on other forms of studies that can look for non-acid reflux. We call that an impedance test. And that can show us non-acid reflux. If that is the case, then in theory, yes, TIF or any kind of a wrapping procedure that augments the sphincter muscle should help. There isn't much data because that population is relatively scant, and I'm sure people would be interested in publishing a series of that if we could get enough patients together. The other way non-acid reflux sometimes gets defined is you have all the symptoms of acid reflux, but you don't have any reflux whatsoever, or at least not enough that breaks any kind of a clinical threshold for the diagnosis of reflux. When we do these tests for the actual monitoring of or measurement of reflux, we have a normal level. The normal level is not zero. There's a certain amount of reflux that is allowed for normal physiology. Some people experience terrible symptoms, and they're real. They experience them despite the fact that the acid levels do not reach that threshold. That we define or call a hypersensitive esophagus. And that means your esophagus is very sensitive to even normal amounts of acid. In those cases, surgery may not be appropriate because it may not completely make acid exposure in the esophagus zero, and therefore you would still be symptomatic. There are other medications we use, like we use an irritable bowel, to try and dull the sensitivity of the esophagus.
Okay, wonderful. Thank you. So another question, Brett Bennett is asking, how do I phase myself off of PPIs?
That's a very great question again. So there is a concept of rebound hypersecretion of acid. What that means is for a person that's been on medication for any length of time, usually more than a couple weeks, the body is ramped up and trying to secrete acid because your stomach and your endocrine system does not know that you are taking medication to stop the acid. And our bodies, for the most part, function on negative feedback loops, which means we sense that there's acid there, so the hormone that tells our body to secrete acid is at a lower level. When it does not sense acid there, it's at a much higher level. So if you're on medication long term to stop the acid, that acid secreting hormone, the one that tells your stomach to make and produce and secrete more acid, is at a very, very high level. So if you suddenly withdraw your acid blocking medication, you could, in theory, secrete a whole gush of acid and really make symptoms worse. That's a phenomena that explains why some people feel that when they stop their medication, the very next day or that same day, they experience terrible symptoms. And they may find that if they hold it out for a couple days or 48 hours usually, their symptoms will improve because that hypersecretion or increased secretion of acid will calm back down to normal levels. So the way we stop the medications, even after a person's had surgery, we don't expect them to have any reflux anymore, is to have them take their medication every other day for a week or so.
Okay.
And then they can maybe stop it if they still experience symptoms and take it every third day and then wean off kind of that way.
So
But for
you
the
wean,
most part, every other day for a week is how we do it after surgery.
thank you. So you wean them off of the
Yeah,
PPIs. Okay. So before we, there's a couple more questions, but I do want to get into the TIF portion of it. Maybe why don't you explain a little bit of how the TIF procedure works for the treatment option?
sure, sure. So for years, and despite many efforts to do things a different way, what has been tried, tested, and proven over time is the best way we currently have to surgically fix or stop a person's reflux is to perform something called a fundoplication. What that is taking the top dome part of the stomach that we call the fundus and wrapping it around the bottom of, hold on, I gotta go this way, wrapping around the bottom of the esophagus.
Yeah.
And that allows us to use part of our own anatomy to augment that sphincter muscle. Previously, it was done all surgically. Before, in the olden days, an open surgery, then more recently laparoscopically, and now with TIF we can do it endoscopically or through the mouth. There are several advantages to this we see. First is that this can be done all through the mouth without having to cut open the abdomen or even make laparoscopic incisions, which greatly improves the recovery. And for some people who have, don't want scars, they don't have scars. Um, and secondly, because we can do this all through the mouth and endoscopically, in many cases we discharge people home the same day. So it becomes a day procedure. I do it in the morning and they go home later that afternoon. And their requirement for pain medication, including narcotics, is minimal, in most cases zero. Um, Third is one of the major Achilles heels of the traditional fundoplication, which we call the Nissen fundoplication, was that despite best efforts and in best hands, it had side effects. I call them side effects because they're not complications. They're not an error in how the procedure was performed, whether intentional or not, but simply the nature of the surgery itself. And
Right.
these problems are swallowing problems, which can occur in 3 to 5% of people, and it can be so severe that they need to be scoped every 3, 6, 9 months and stretched out, or a condition called gas bloat syndrome, which can occur as high as 10 to 20%, according to the literature, of patients that have this Nissen surgery. Gas bloat syndrome is a sensation of fullness, bloating, and nausea.
Mhm.
It occurs intermittently, but it happens quite frequently, and it doesn't have any remedy. You can't undo the Nissen, and really no medication work for it. We
Okay.
think this happens because the nature of the surgery requires that a surgeon dissect the stomach free from its attachments and sometimes causes nerve and blood vessel damage in order to mobilize the stomach enough that they can perform this wrap. When they do that, again, it causes that nerve and possibly blood vessel damage, and that leads to a motility problem with the stomach. Undoing it would be of no help because once those things are damaged, those structures are damaged, they're damaged, they don't repair themselves.
Got it.
By doing it through the mouth endoscopically, we're able to use whatever laxity the body gives us in that tissue, in that dome part of the stomach, and use that to create the wrap.
Mm.
As a consequence, since there's no dissection on the outside of the stomach, there isn't damage to the surrounding structures or the innervating nerves or blood vessels, and therefore we don't experience those same symptoms. So when I consent patients between a Nissen and a TIF, I often tell them that with the Nissen, these are the worst things that could happen. You
Mhm.
may have swallowing, you may not have any reflux anymore, but you may have chronic swallowing problems or this gas bloat syndrome. With TIF, the worst thing that can happen is it didn't work. And we can talk about those proportions in a minute if you like. Um, and if it didn't work, you still have the same three options available to you as a patient today or then as you do today, which is medication, doing the TIF, or having a Nissen. So TIF also doesn't burn any bridges.
Right.
So that's why we think it's a great first line option and something that allows us to treat more and more people. Because of the side effects I mentioned earlier, many doctors and patients, no, doctors were nervous referring and patients were nervous undergoing the Nissen, and they would compare the likelihood of those side effects and the effect of those side effects on them with their current symptoms of their reflux, and try and weigh which is better to have to deal with.
Right.
And many people would choose their reflux. Only
Right.
the most severe would ultimately, I think, decide on the Nissen. Now, because we have a much safer procedure, which is almost as effective, we're able to treat a really wide spectrum of patients in their disease process.
I love that. Thank you so much for the explanation. As you were explaining, lots of more questions have popped up. So we're going to try and answer as many as we can today. We have Mary Ellsworth asking, after you have the fundoplication like I had, how long does it take for your esophagus to heal? I'm still having trouble eating.
Right. So there is a diet that we prescribe for people to follow post-procedure. And the reason for the diet is we do expect some swallowing difficulty in the beginning. And the reason for that is the work that we've done here in this area, I can't reach for some reason, uh, is there's going to be some swelling there. And that, so naturally, it's going to be narrow, and it will take some time for you to be able to tolerate solid food. So my practice is to ask people to consume a soft, or actually a puree, up to a puree consistency. So liquids and up to a puree for 2 weeks. At that point, I then ask them that they can increase to soft foods for another 6 weeks. And I define soft foods as anything other than meat, bread, or uncooked vegetables. So anything that in theory could get stuck. Because if things get stuck, it's not necessarily that those food items themselves will cause reflux, but if things get stuck, they would possibly cause a person to retch. And if they retch too soon in the recovery time period, they could disrupt the TIF.
Right.
Having said all that, everybody is a little bit different. I would say 95% of our patients, when I follow up with them 4 weeks afterwards, are tolerating a soft diet just fine, and eventually go on to tolerating a completely regular diet by week 8. There are a few that still have some trouble by week 4, week 5, week 6. I don't over investigate that unless somebody is having problems beyond the second month or into the third month. And we have not experienced that as of yet. It is very important to make sure that your esophagus has good motility before you undergo any kind of surgery for reflux, because we are tightening things up. So we want to make sure your esophagus has enough strength to overcome that. And I do that via an X-ray, and there's other more sensitive tests if needed to confirm that.
Wonderful. Thank you. So we have another question from Cheryl Scott. I have TMJ. Whenever I have GERD, it flares up. My TMJ flares up also. Why does this happen?
The only thing I can think of would be if when your natural reaction, I think if you're particularly if you're regurgitating up into your mouth, is to excessively swallow to try and get that back down. And in some way, if that's that motion, that jaw motion is triggering the TMJ, that would be what I would think of.
So, okay, thank you. And then Grudy has another question. How long does the TIF last?
All right. So the data we have is up to 5 years of following patients prospectively. And in that, we saw that over about 90% of people had still a good durable result by year 5. Most of those people were completely off their medication. A small percentage needed their medication once in a while, which is perfectly appropriate. Sometimes you need medication, once or twice a month. I don't consider that to be that the TIF didn't work or any surgery didn't work. That's sometimes just normal physiology or based on a person's lifestyle. One of the reasons some people may feel like it didn't work earlier than that is weight gain. So people are often reminded not to overeat when they have reflux by their reflux. And when they no longer have reflux, they no longer have that mental cue. And I have seen people gain significant amounts of weight afterwards if they're not careful. And the weight gain and the obesity itself can lead to some reflux symptoms, even though the TIF is completely intact. So that's something I do caution my patients about when I follow up with them, to keep an eye on that.
That's okay. Thank you. Somewhat Kathy Ellis Knight's asking, so do you suggest surgery or pills for GERD?
Depends what phase of your reflux you're in, what your symptoms are, and if you are getting complete relief with your medication. So if you are only experiencing heartburn and it's not extremely severe and it's relatively infrequent, less than once a week or so, and medication completely solves your problem, then I have no problem with patients taking it even long term at once a day standard doses.
Okay.
If medication is not resulting in complete relief of symptoms at once a day standard dosing, and patients are requiring more than once a day, so twice a day, or even with twice a day, they're still regurgitating, then that certainly is an indication to consider surgery. Some people are nervous or don't want to take medication every day for many reasons: fear of side effects, pill burden, cost. Insurance companies more and more aren't paying for it and forcing patients to spend their own money out of pocket. Then that is a reasonable reason to consider pursuing TIF, as long as you understand the possible outcomes.
Okay, fantastic. So there's always been a lot of questions about PPI and long-term use with PPI. Or do you want to comment on any? I mean, you did comment a little bit about that. And
yeah, sure.
Yeah.
So over the years, particularly the last 2 years, there's been a growing interest in potential side effects of these medications, and there's a list of them. The ones that people ask me the most about, or primary cares kind of take things into their own hands and stop the medication for, are bone loss or at least fracture risk, heart disease, Alzheimer's, and kidney disease. Most of this data is still unclear. Most of the studies that were done are what we call retrospective, which means looking back in time. Studies that look back in time are very helpful in us in identifying future areas of study, but do not prove causation. Without definitely proving causation, we can't say for sure that these medications are causing these problems, but there is reason for concern. If a person is requiring medication twice a day, that certainly increases their risk of some of these possibilities, and that's why I like to intervene in that situation. If a person already has osteoporosis and their primary care doctor is worried about the medication contributing to that, that's a reason why we offer surgery. We're seeing more and more patients being sent from their kidney doctors because of kidney function deteriorating. Now, whether or not it's proven to be causative or not, their specialist feels that it may be that case, and if we have a good opportunity to get them off their medication, and see if their kidney function improves, particularly with a surgery that's safe, then I think it's very, very reasonable. The Alzheimer's notion, I think, has been kind of debunked, and the heart disease one is kind of unknown at this point either, so we don't put too much weight on that. Another reason I have done this procedure in patients due to fear of medication side effects is an infection in the colon called Clostridium difficile, or C. diff. That's an infection that can lead to diarrhea. It can be very, very difficult to treat. This bacteria is becoming more and more resistant to antibiotics, and some people may have heard of the use of stool or fecal transplant to treat this because of the resistance. So we have had people that have had recurrent C. diff infections. We think this medication may increase the risk of recurrent infections, and for that reason, we have done the surgery so that they could come off their acid reducing medications and help reduce the likelihood of their C. diff recurring.
Interesting. I haven't heard that one, so that's interesting. Thank you for sharing that. We're coming up on the half hour, so there's a few questions, but I do want to ask maybe one or two more here before we head out. Someone's asking, I have esophagus Barrett's esophagus, but no heartburn, but have LPR. Does that mean I have acid reflux?
Yes, LPR just refers to where you're experiencing your symptoms. So LPR means laryngopharyngeal reflux, which means up here. So in order for you to be refluxing up here, it had to have come from down here. So you do have GERD. Your symptom of your GERD is LPR. And the further evidence that you have GERD is you have Barrett's esophagus. That's what GERD is what we believe is what causes Barrett's esophagus in the right genetic environment. Um, LPR is one of those symptoms that often do not improve with medication because it's not necessarily the acidity that causes the symptoms. It's the physical material coming up from your stomach into your esophagus and higher in this case. So this would be a very good reason to undergo some sort of restorative procedure of your anatomy and of your esophagogastric junction.
Perfect. Thank you. So one last question. We had a question on our Facebook page earlier today. Are any doctors doing the procedure right now, the TIF procedure, obviously? Due to COVID, I would think there are none. What are your thoughts on that?
So I think this is, I think this is very regional. It really depends on what the disease burden of COVID has been in your local community. Fortunately, thus far, where I am, although it certainly has impacted us, we have started to open up and do more and more elective cases, including the TIF procedure. If you talk to some people who have terrible reflux, they don't think that correction of their reflux is elective. They are miserable.
Right.
And again, for the most part, these are people in whom medication isn't working. So now that capacity is there in local hospitals to handle COVID patients, both from a bed situation and a PPE situation and a ventilator situation, we're more and more comfortable performing procedures that are really needed but not emergent. So we have started as of late May, starting to do this again, and certainly the workup. There's a workup that's involved before we would do surgery, and we're doing those as well.
Okay, fantastic. And maybe you can address a little bit. I know some patients are kind of worried about going into the doctor's office right now. There's some, myth, oh my gosh, I don't want to expose myself to COVID. And a lot of other doctors are doing some telemedicine. Are you doing that right now? Taking kind of initial consults with telemedicine, just to kind of make the patient feel a little bit more comfortable before they have to come in and do all of the diagnostic testing?
Absolutely. I think it's very important to develop some sort of rapport with your physician before they do a procedure on you, particularly for something that is geared towards diagnostic as opposed to just a screening test. So for that reason, I see all patients, and for the most part, we encourage everybody to do telemedicine because it is safer, both for the patient and for my staff and for myself. And I have to be cognizant of that as well because I have to see sicker people in the hospital as well. So it's part of my responsibility to stay as healthy as I can. So for that reason, we're doing telemedicine. I can get all the information I need from a patient and simply talking to them, and make a decision based on that, what the next steps would be.
Fantastic. Wonderful. Well, thank you again. That's all the questions. If I did not answer all of your questions to the Facebook viewers, we have a TIF talk every Tuesday. So we will more than likely have those questions to ask the next doctor. But for now, Dr. Raza, is there anything you want to leave the audience with? Is there a closing that you want to say about, GERD in itself and the TIF procedure?
Absolutely. I think in this day and age, in 2020, do not settle. If you feel like your symptoms are not completely treated, we can do better. There are safe options available surgically that will do better than just medication in most cases, and allow you to come off your pills if you don't want to be on them, even if they are working well for you. So as that would be my advice to people. And I think that's really what this PPI scare that all these side effects were talked about brought to the forefront, is it really identified people that were just settling for treatment. They were, they didn't have ARPA anymore, but they were still sleeping up in their lazy boy at night because they couldn't lay flat at night. We don't want that. You should expect more out of us, your doctors. So please let us know you're out there, and we'll help.
I love that. I love that, Doctor. You're so great. Thank you so much. I can't thank you enough for being here and joining us today and helping all of these people that have questions about GERD and the TIF procedure. Again, please feel free to jump on to our TIF Talks every Tuesday. They vary in times depending on who our guest speaker is. If you are in the Elkhart, Indiana area, you can definitely get a hold of Dr. Raza and his practice. But if you are not and you're looking for a physician, especially if it's specific to the TIF procedure, you can visit gerdhelp.com. And on there's a lot of information about GERD treatment options, and then obviously the TIF procedure. In addition to that, there is a physician finder. So you can put in your zip code or your state, and you'll be able to find a doctor that's near you in your area. So again, I can't thank you enough, Dr. Raza. We appreciate it. And thank you to everyone watching tonight, and we'll catch you next Tuesday. Thank you very much.
Thank you, everybody. Be safe.
Thanks.